connected and known to be connected to contained outbreaks and complex cases. 289 of those are under investigation by our public health team. I'm very sad to have to report that there have been 2 further Victorians pass away, bringing the total number of deaths as a result of this virus to 29. The 2 gentlemen who passed away were in their 80s. I'm not in a position to be able to provide any further information about those cases, but we of course send our best wishes, our thoughts, our prayers to each of those families. This will be a very, very sad and challenging time for them. There are 109 patients in hospital. 29 of those are receiving intensive care. Yesterday we had 28,607 tests that were undertaken. That brings to a total of 1,225,999, the total number of tests that have been undertaken since January 1. As I always do, because it's critically important, can I thank those nearly 29,000 Victorians who came forward and got tested yesterday. It's a massive and powerful contribution to our fight against the virus. You can't contain this if you don't know where it is. And the most important thing for people to do, apart from of course following the rules, using common sense and good judgment, is to come forward and get tested if you've got even the most moderate, the mildest of symptoms. That really does give us the data, the intelligence, the clear information that our coronavirus detectives can then use to contain further outbreaks and to bring some stability to these numbers. We have 2,128 active cases. Obviously, we are seeing some relative stability to these numbers. We've always made the point that with these stay-at-home restrictions only just a week old, it would take some time to bring that stability to the numbers, and then of course to then starting to see a pattern where they are driven down. One of the key challenges, beyond the fact that this is wildly infectious and you can be infectious and only have very mild symptoms, if symptoms at all, one of the other challenges of course is that the life cycle of this virus means that actions you take today, the impacts of which are not really clear or well known or understood or reflected in data for at least a week, and to be safe, really 2 weeks' time. That's why this is a 6-week stay-at-home lockdown. That's 3 full life cycles of this virus. At the same time though, we are seeing international evidence and indeed some evidence across Victoria and across our nation that people can still have low levels of virus, be not particularly infectious, but test positive many weeks after they had initially tested positive. Symptoms are sometimes aligned with that, sometimes they aren't. That's that point about it being quite a cunning enemy. It's very, very challenging for us to be across every single case and for every single person to do everything they can to limit the likelihood of infecting someone else. That's why it's so important that these rules are followed, and I thank every Victorian who is following the rules. That is the vast majority. We do continue to see a smaller number of people making choices that not only are they wrong, but they're not particularly smart, because Victoria Police are out there, and as we heard yesterday from Deputy Commissioner Nugent, Victoria Police are out there in force. They are doing the work that needs to be done to make sure that people are complying with these rules, to make sure that everyone's playing their part, large and small, in our efforts to defeat this virus, or at least to stabilise, drive down and then contain at low levels the amount of virus across the Victorian community. Now I know there's been a lot of discussion, a lot written and said about possible stage 4. There are no announcements to be made about that today. That shouldn't be read to mean that there will be announcements made tomorrow. We of course plan for every single contingency, but it's well too early for us to be moving to a whole new stage. This is in the hands of every single Victorian though. If you want to make that less likely, if you want to get out of these sorts of restrictions as fast as possible, then we all have to play our part, not rely on our doctors and nurses as the last line of ultimate defence against this virus, but instead acknowledge that we're the ones that are on the front line. Every individual, every family, every local community, the choices that we all make absolutely determine how many people get this virus, how it spreads, and how long those restrictions will be in place for. That's just the fact of it. We've all got a stake in this. We've all got a role and a role to play and a contribution to make. And if we all do that, then this strategy will be successful, just as it was last time, just as it has been in so many other countries who are dealing with second waves. I mentioned Israel yesterday. There are a long, long list of nations around the world that are dealing with second waves, and the best way to deal with it is to have settings in place that are proportionate to the challenge you face, and then have a very high degree of compliance across the community in recognition of what's lawful, in recognition of what actually works, and in recognition of the fact that no family will be spared the cost of this virus, the pain of this virus, if we don't get it under control. That is the fact of the matter. I again take this opportunity to thank everyone who's coming forward to get tested, to thank the literally thousands and thousands of people who are working day and night to provide the very best response possible to this wildly infectious global pandemic. They are doing a mighty job, and I'm very proud and grateful to all of them. Equally, I'm very proud of and grateful to every Victorian who is doing the right thing. That is the vast majority, but we've just got to stay the course on this. We've got to keep following those rules. They make sense. I know they're challenging. I know they're frustrating. Everyone would prefer this to be a very different set of circumstances, but it's not an ordinary winter. This is not an ordinary week. And if we pretend that it is, if we pretend that it's over because we want it to be over, then all we'll be doing is spreading the virus, seeing more and more people in hospital, and sadly, more and more people that will pass away as a direct result of this virus. Now, on the issue of hospital system preparedness, I think we've made a few comments throughout the week that we'd soon be able to give you an update on gloves and masks and shields, beds, ventilators, the sort of treatment space work that we've been doing in a whole range of different settings. I've now asked Jenny to take you through some of those facts and figures, if you like, some of the investments we've made, some of the effort that we've put in. Of course, there will need to be more if the clinical circumstances change, if more and more patients present to healthcare. It's always important to be a step or two in front of this, and when it comes to health system preparedness, we most certainly are. Just before Jenny goes through some of the facts of those matters, can I just send out a really clear message to every health worker, regardless of the role that you play, whether you're clinical staff, whether you're a hospital cook or cleaner, a nurse, a doctor, an AMBO, somebody working in a laboratory. We are all so grateful to you and so proud of your care and compassion, your absolute commitment to doing everything you can for every patient that you treat, every person in the system that you are part of. We are deeply grateful to each of you. We want to do everything we can to keep you and your family safe. We want to do everything we can to honour the work that you do and to make sure that you're supported with the equipment, the technology and the absolute resolve to make sure that there is everything necessary to provide the best care to anybody who needs it. Thank you so very much for everything you do, not just during the pandemic, every day, every hour of every shift. You do an amazing job and we're very grateful to each of you. I now might ask Jenny just to take you through some of that investment, some of the preparedness work that we've done, and then of course we're happy, we might get Brett just to speak about circumstances of the day, and then we'll take any questions you've got.
Good morning and thank you, Premier. Earlier this year we announced $1.9 billion investment to create more ICU beds, to purchase the PPE and the critical medical equipment that we need. And our health sector has not stopped preparing since this pandemic started in January. We have created more ICU capacity, more beds in our hospital system, and we have undertaken extensive training of our staff. And I want to take this opportunity to thank all of our health services for the enormous work that they have done. They did not pause that work even when the numbers started to trend down. So our health system, our hospitals are well prepared to respond to this second wave of coronavirus cases. So just as we We announced that $1.9 billion. You might recall that we had made a commitment to create more ICU and critical care beds in our system. And to date, I'm pleased to advise that we have established more than 1,000 ICU and critical care beds in our hospitals right across Victoria, from metropolitan hospitals across to regional communities. One of the key features of that undertaking was to actually create new spaces to recommission hospitals and spaces in our health system that had not been used for some time. The old Peter Mac Hospital was one of those projects, and this has been a $30 million project to recommission 84 additional beds that are now available to our hospital system. That will now be called St Vincent's on the Park. Those beds will be managed by St Vincent's Hospital, given the proximity to their main campus, and this will enable them to have patients move there and to create more capacity to deal with coronavirus patients on their main campus, close to their emergency department and to their ICU beds. So this is going to be a very significant addition to our health system, and for media, they'll have the opportunity to have a look at that facility later today. So I want to take the opportunity to thank the 650 construction workers who worked over 60,000 hours to recommission the building. The building is now state-of-the-art for a very old building in terms of the space there that's now available for additional patient capacity. But we've also worked across our health system to create more hospital capacity in many, many locations, from bringing forward and fast-tracking the commissioning of Casey Hospital to creating more bed capacity at Baxter House in Geelong, at Bendigo Hospital, at Shepparton Hospital. We have made sure that there are new ICU beds going in many, many locations right across Victoria. And we have, of course, contingency plans there should it be required to exceed what we have already delivered, but we hope, of course, that that capacity will never be required. It is on all of us to do the right thing to make sure that our last line of defence, our healthcare workers, do not need to be stretched and do not need to be dealing with many hundreds of patients or thousands of patients for that matter. In terms of other capacity in the system, as was the case back in March. You may recall that the National Cabinet at that time made some decisions around pausing elective surgery. I'm announcing today that we will take similar steps to create additional capacity in our hospital system. We will pause all Category 3 surgery across our hospital system, and our hospitals that were reaching close to 90% of normal activity will now pause at 75%. So this is for all metropolitan public hospitals. Will pause their elective surgery activity at 50%. They'll come down to 50%, and our private hospitals will come down to 75%. So just to be clear, in terms of the timelines of where we were tracking, we were due to go to 100% of normal activity in our public hospitals by the end of this month. We think it's necessary now to create additional capacity by bringing public hospitals down to 50% and private hospitals down to 75%. There have been lots of discussions with the AMA and health sector unions about this, and there is support for this step at this time. This will mean that our private hospitals will be able to assist us with undertaking urgent surgery, so Category 1, Category 2 surgery, which is emergency surgery. The most serious surgery will still be able to continue as per normal, but we are creating more capacity in the system to deal with more patients. I think you're aware that we have seen an increase in hospitalisations in the past 2 weeks, as the Premier outlined. Today we have 109 patients in hospital, and 29 of those patients are in intensive care. That's an increase of 2 since yesterday. But thankfully those numbers are still relatively low. We want to ensure, of course, that there is no one in intensive care, and this is why it's incumbent on all of us to follow those stage 3 restrictions very closely. In terms of other hospital preparedness, as I said, there's been a power of work that's happened since the start of the year. We created a centralised warehouse and distribution system for PPE, and we have many hundreds of millions of items sitting in our warehouse and being distributed to our health services each and every day. So, 32 million masks and 90 million gloves. There are ample supplies of PPE available to protect our dedicated healthcare workers. And in terms of medical equipment, we have spent hundreds of millions of dollars securing the critical medical equipment that we need to convert beds into ICU beds, and that means that we have secured already 1,200 ventilators that are available in our hospitals. There are hundreds more sitting in our warehouse and thousands more still on order that are arriving each and every week and being distributed as required. So our health services are very well prepared to respond to the increasing hospitalisations, but we hope that this additional capacity will never be needed. If everyone follows the rules and stays home as much as is possible, we will not see more people end up in hospital. I'm very saddened to see many elderly Victorians who have passed away in recent days. We know with the increasing numbers that we may well see more people lose their life or end up in hospital. So it is important that we continue to take this pandemic very, very seriously, that we do the right thing, and that we keep our health system able to deal with cardiac patients, with cancer patients, and with all the other presentations that will occur. So I just want to finally thank our dedicated healthcare workers, as the Premier did also. They are our last line of defence. We are all the front line. Our dedicated nurses, our doctors, and all the other hospital staff who are working night and day to keep us all safe need us all to do the right thing, and that is to abide strictly to the stage 3 restrictions. Thank you. I'll ask now Brett to say some words about today's outbreaks and cases, and then we're happy to take your questions.
Thank you, Minister. So 317 new cases today. That is our biggest daily increase. I said yesterday or earlier this week that we hadn't hit our peak. We may still not have hit our peak. It's a big number. It needs to turn around. In some ways, I expect it to turn around this week, but as I've always said, it's no guarantee. It's upon all of us to be able to turn this number around. The restrictions, the stage 3 restrictions, have been in place for over a week, with an average incubation period of about 5 or 6 days, plus the time for notification to get these numbers in. We would really expect a plateauing in the next couple of days. But we cannot be complacent and expect that that's going to happen automatically. It involves everyone limiting their interactions with others, staying at home as per the directions, only leaving for those essential reasons, and absolutely isolating if they are unwell, getting tested and waiting for that result before they have any other interactions with their close contacts. A number of outbreaks now in aged care, 27. A number of healthcare workers infected. This is where the virus manifests in the people who are most exposed to it and in those individuals who are most vulnerable. And the deaths that have occurred, 29, again, not unexpected when these settings are affected. I'm still reading the counterfactual that 29 deaths is not much compared to an average flu season. These are the deaths that you have when you have your controls in place. When you do not have your controls in place and the restrictions that we have applied across Metro Melbourne and Mitchell Shire, and indeed across the state to some degree, you get 1,000 cases a day. You get up to 10,000 or more cases a day, as has occurred in some countries, and you get up to 1,000 deaths per day, as has occurred in countries in Europe, in Brazil and elsewhere. And so the idea that 29 deaths is nothing, and that we can lift all restrictions and that we can let it run is absurd, because it's an exponential growth in cases when there aren't restrictions in place. If we can drive numbers right down, and if we can follow them through a test and trace procedure, then we can avoid all of the worst outcomes of this virus. But we shouldn't look at that number of 29 and think we're being excessive in our response. This number is where it's at, absolutely by virtue of what we've done. And if we don't do it, it'll be hundreds or thousands of deaths. Some outbreak updates, and there'll be much more detail in the healthcare worker health setting outbreaks and the aged care outbreaks in the Chief Health Officer media release this afternoon. But there are 157 cases now linked to Al Taqwa College, 6 cases linked to HWL Ebsworth Lawyers in Melbourne. So there are office-based outbreaks that can occur as well. We shouldn't just think of those highest risk settings. Anywhere where people are coming in close proximity is a risk. So again, everyone should reflect on whether you have to be on site for work purposes or whether you can work at home. There are 37 cases now linked to Somerville Retail Services in Tottenham, 31 cases linked to Menarok Life Aged Care Facility in Essendon, where the residents have been moved to acute care services. 5 cases linked to St Basil's Homes for the Aged in Fawkner, 23 cases linked to Glendale Aged Care Facility in Werribee, 21 cases linked to Estia Health Aged Care in Ardea, and 29 cases now linked to JBS Abattoir that's closed in Brooklyn. And I'm happy to take questions.
Of the cases that are still under investigation, can you give us a sense, are they mostly in that, still looking at that main northwest region?
They are still very much in the northwest corridor. The Hume and Wyndham local government areas in particular, but also Brimbank. There are some, particularly hot postcodes within those areas, but there are dozens and dozens of postcodes affected across Metro Melbourne. So we shouldn't have some idea that the risk suddenly drops off at one geographical point in Metro Melbourne or indeed in Victoria.
Are we seeing the same short incubation period that New South Wales reporting?
I think the short incubation period that New South Wales is talking about just relates to the transmission event that happened at Crossroads Hotel. If someone's extremely infectious, then people can get a very high viral dose when they're exposed, and they are probably more likely to develop illness much earlier. It's not a different virus, just relates to the particular event that happened at Crossroads and how infectious that index case was.
Have we seen similar cases in Victoria of people being infectious quickly, I guess? Or?
Yeah, there will be some people who have developed symptoms 2 days after exposure. We know that that's in the spectrum of when people can develop symptoms after being exposed. It's really from 2 days up to 14 days.
A lot of people might be scared that it's the biggest daily increase. What did you think? What would you say to people who get terrified?
We have significant controls in place. We have the kind of restrictions that worked through our first wave. I expect them to work through this wave. It is somewhat more challenging, as I said yesterday, because of the family sizes, because of the networks of individuals who are connected to cases. But we also know that the mobility data is telling us that people have significantly reduced their contacts, and we know from following up our cases that the number of nominated close contacts is much less than it was a week or 2 weeks ago when it was 5 or 6 individuals. It's heading down towards 1. They're all good signs. I expect that we can turn this around. If it's not turning around, I know that we will do whatever is required to make it so.
And does that mean it's under control? I mean, can people feel like it's under control or not?
Yes, I think so. Look, an out-of-control outbreak is one where no matter what you're doing, you're seeing a really significant exponential increase. We're seeing an increase, but it's relatively slow. We've done further calculations on the effective reproduction number, so the kind of rate of increase that is being modelled. It's also coming down close to 1, where we expect that plateauing of cases. So they're all good signs, and I think they are a measure that we're getting it under pretty significant control.
How much of the new numbers are from the towers, and are you seeing the towers becoming a source of other infections outside them?
No, I think, you know, we're clearly seeing ongoing numbers in the towers. That's not unexpected with all of the close contacts that were identified with. No, across the towers, but again, there were individuals in families where there were close contacts who were always going to develop illness. And so some of the new cases in those towers are absolutely not unexpected, but we need to make sure that all of those new cases are appropriately isolating, that we're facilitating their isolation and the quarantine of their close contacts. I don't think we are seeing spread from beyond those towers with the controls in place at the moment, but we absolutely have to support people in order to ensure that that risk doesn't occur.
What is the number of current active outbreaks?
Justification please for keeping the genomic sequencing data under wraps at the moment?
Well, it's not my genome sequencing data to share, for a start. It belongs to Peter Doherty Institute, who do the sequencing at the Microbiological Diagnostic Unit and the reference laboratory Vidril. The judicial inquiry has made, under its terms of reference, the more contemporary genome sequencing, and so I don't want to be commenting on it when it's going to be investigated very shortly.
But isn't it vital public health information, or certainly relevant public health information to the pandemic, that should be out there regardless of any other processes?
Well, it'll be absolutely subject to the judicial inquiry very shortly.
But are you comfortable then with it being kept under wraps in the way that it is right now?
It's not my call to keep it under wraps, Noel.
But are you comfortable with the call that's been made?
I don't have an opinion on it. I'm very happy to speak to it when I'm asked about it, if I'm asked about it in the judicial inquiry.
Just to clarify, how many active outbreaks is currently being monitored?
I think it's over 160 outbreaks. We really do have to go through 2 full incubation periods of no further cases to call an outbreak closed. So there are a lot that aren't active, where we're not seeing new cases occur and we don't expect new cases to occur, but they're still on the books in terms of being called active.
And when does it become an outbreak? What is the...
Look, it really depends. If we get one case in a staff member or a resident in an aged care facility, we call that an outbreak, even with one case, because of the urgency of the response that's required. But other outbreaks really relate to transmission between individuals in a setting outside of a home.
The 109 people in hospital, are they mainly elderly people, or are you seeing a spread that's getting into other kids'
Look, the most vulnerable people who will be much more likely to require hospitalisation are the elderly, but we know that there are people in their 30s, 40s, 50s and 60s in hospital at the moment, and so we shouldn't expect that this is an illness that only affects the very elderly. There are people who have died in their 20s and 30s in large numbers internationally, and if we get significant numbers of people in those age groups infected, we can expect deaths in those age groups as well.
Have any of those recent deaths been linked to clusters like the towers or any of those key clusters?
Sorry,
have any of the recent deaths been linked to those?
I don't know if the deaths are linked to particular clusters. I know that some of them have been related to aged care facilities. Again, tragic but not unexpected.
Do we have any cases of people that...
Just on aged care, there seems to be, and we talked about yesterday, the fundamental problems. Do we need to see some more action from the federal government in terms of the fundamental structure of how the aged care homes in Victoria are working under these extreme conditions because of the spread?
Look, I don't know that it's for me to be able to make a judgment now. Indeed, but I'm in the response phase of this pandemic. We are doing everything that we can, identifying and mitigating the risks that we see. In terms of the broader structural elements of staffing and infrastructure in aged care, that's not something that I'm looking into now because I'm not about to change it. We are doing everything that we can to make sure that the risk of transmission in those facilities is managed as best as possible. That absolutely involves an immediate response to the first cases, an immediate review by our outbreak squads, a review of the infection prevention and control procedures in place, the question of whether people need to be transferred out to acute health facilities, and all of the the preventive work that we're doing with our infection prevention and control squads going out to these facilities to make sure that they've got an outbreak management plan, to make sure that they know all of the things to do with respect to infection prevention and control. And of course now recommendations on mask wearing for all staff. They're all the important things that I'm focused on at the moment.
But clearly we've got major outbreaks in several aged care centres now. Clearly something's not happening somewhere that should be happening. Do we need to start moving every COVID patient out of these locations? No,
I don't think that moving residents out who are infected is always the control measure that's required. The primary thing is never to have infection introduced in the first place. Aged care deaths contributed to a third or a half of deaths in European countries. We are not seeing that. But we've got a number of aged care facilities that are infected at the moment. We need to focus on making sure that the staff who are turning up positive are excluding themselves at the very first symptom, are getting tested, and that we're getting that very broad testing and making a response as soon as we identify resident cases.
Can you just explain why you're reluctant to move the patient straight out? Because there's people running nursing homes, there's people who've got a relative next to someone who's positive. Can you explain why you're reluctant to move?
Oh, it's not a reluctance, Raf. It's a judgment based on the setting individually. So there are some settings where it's pretty clear that infection prevention and control can't be managed easily. If there's a shared bathroom, if you've got demented patients who are very prone to wandering. There are other settings where they are much better managed on site, where it can be controlled, where the infection prevention and control measures are done as well as they might be in an acute care facility that, as we know, are going to be under pressure with both healthcare workers under furlough or quarantine and other healthcare workers who are unwell, and looking after a number of acute coronavirus cases. So it's a judgment on each and every setting, each and every case.
Just following up on nursing homes again. Earlier in the pandemic, we saw outbreaks in nursing homes, 2 and 3 in nursing homes, but we didn't see that take off. So what's gone wrong here?
We've certainly got a bigger volume of community transmission that's happening in Melbourne through this phase compared to the first one. When there's a lot of community transmission, then the workforce for aged care and for healthcare are exposed both in the community as well as potentially in those settings. I think that's what we're seeing. We're seeing staff members, especially in the higher transmission areas, who are being exposed to the virus. As we really ramp up the stay-at-home directions, we're hoping that their exposures are limited to the fullest extent possible. They still have to do that work. They're still going to be in close contact with those residents, but outside of the work setting, they need to minimise their exposure as much as possible. Have somebody else do the shopping from home, make sure that they're limiting their interactions with anyone else as much as possible.
Has the casual workforce been a factor in those aged care homes, given a lot of staff are casuals and some work across multiple facilities?
Yeah, we have seen some seeding between one aged care facility and another because of staff who work across those facilities. We've provided a policy guidance to ask aged care facilities to minimise that to the fullest extent possible, but we also know that some wouldn't be able to function if they didn't have that flexibility in place. But it's a risk, and we need to manage it as best we can.
How many healthcare workers in hospitals have the virus or are currently in isolation with this exposure to the virus?
We might be able to provide that in the afternoon update.
Is that a concern for you that this is happening as outbreak in Northern Hospital's got quite a few?
Oh, of course it's a concern to see healthcare workers exposed. I know that some of them have been exposed because they've been interacting with patients, and maybe those patients haven't been identified with coronavirus very early on because of unusual symptoms, but also there's staff-to-staff transmission that's occurring. I've made the point before that PPE is available and it needs to be worn universally, but no one can let their guard down in terms of where they're wearing a mask or where they're trying to keep a distance, including when they're with other healthcare staff in the hospital setting.
Practices may not be followed in hospital settings, the best practice?
I know that all hospitals will be looking at it really closely and trying to do everything in their power, from a safety and quality point of view. I think, we never stop trying to look into how those exposures might be occurring and doing everything that's possible to protect those healthcare workers.
And if you've got people in hospitals wearing masks, is the consideration of mandating masks, is that separate to whatever stage 4 is? Or is it still possible that we might all be asked to wear masks in the next phase?
I'll certainly keep the mask policy under review continuously. If there are other settings, other individuals or occupations where mandating mask use is more appropriate, that's on the table, absolutely.
Do we have any cases of secondary infection where they've recovered from the virus?
No, not that I'm aware of. I know that there's been talk of individuals who have had the virus detected some weeks after they've recovered. That's probably not a new infection. That's probably just persistent virus. It's probably dead virus that's still picked up on a genome test like the PCR test, but isn't representative of really being infectious.
If we do move to stage 4, what would it involve? What other measures would you be considering? Obviously, you're not going to say what you are implementing because you're not doing it yet, but what have you got left in the bag? All of the decisions around stage 4, if we have to go there, will be based on the epidemiology. So seeing where the ongoing transmission is occurring, even as stage 3 restrictions are in place. So again, I don't want to preempt any possibilities, but we really need to look at where the risk continues to persist in terms of transmission. And where do you think that risk is at the moment? Obviously, it's in essential workers who are probably going to have to keep going to work even if there are further lockdowns.
Yeah, I think some of it will be work related. Obviously, essential work is essential and needs to continue, but to really focus on how to manage the risk of transmission in all of those settings. But for other workplaces also to consider how transmission might be occurring there. Again, if it's a compliance issue of people working on site when they actually could be working remotely, that needs to be looked at as well.
When you first say that suburban lockdown didn't work, that we should have gone to full lockdown across the Melbourne metropolitan when we went to the hotspots instead?
We are always trying to balance a proportionate response in terms of understanding what it means to close businesses, to cause economic and psychological and health hardship and suffering for individuals. And so the postcode lockdown, if you like, was trying to put the brakes on the transmission that we saw, very focused in those areas, to see if our test and trace could get on top of all of the other smaller numbers, 2, 3 in other postcodes. That didn't occur. So it was insufficient, but we needed to see what the transmission dynamics were like. Was it something that we could get on top of with following individual cases, or did it need that broader measure? When it was pretty apparent that it was ticking up, it was only within 24, 48 hours that we went to that full Metro and Mitchell Shire lockdown.
Greg, I'm not sure if this is one for you or for the Minister, but the department currently allows visitors to palliative care wards under COVID restrictions. We're aware of one health service that's only allowing visitors if the patient is just hours from death. Should they be re-looking at that given what other health services are allowing?
It is a call of an individual health service, but AHPPC, which I'm a member of, has recommended that that's an exemption for people to make visits. I would say that it's an important visit to make, we don't have a policy lever to enforce it as being an available thing or to shut it down. But I would say that it's with health services, but my personal view is that it's a very important potential interaction as people are dying.
Can I ask the Premier about elimination versus suppression? The top doctor advising you constantly says he's in favour of elimination.
No, that's not quite what he says. That's not quite what he says, Raf. What he says is that if a successful suppression strategy can deliver an effective defeat of this thing, so that we've eliminated it to the point where we've got 0 cases, then that's a terrific byproduct of delivering the current strategy, the National Cabinet endorsed strategy. I said yesterday that we're essentially in the midst of trying to establish whether we can suppress and not have multiple waves. That's the real-time work that we're doing now. But you've got to order your thinking and order the work that you do. And the most important thing at the moment is to have that sense of control, drive those numbers down, see community transmission at but a fraction of the rate it's running at now.
Do you think it's possible to eliminate transmission, community transmission? Is that something you'd like to aim for?
Well, it's certainly our aim. That is absolutely our aim. And that's what the next 5 weeks is all about. And again, to earlier questions about what subsequent stages might look like, to earlier questions about, you know, what are the other levers that the government can pull. The key point here is that's in the hands of every single Victorian. And whilst I'm very grateful to the vast majority of people who are doing the right thing, we are still seeing people visiting family and friends as if there wasn't a global pandemic, as if there wasn't rules in place. We just can't have that happening. People going to restaurants and thinking that it's a fundamental human right to be able to sit and eat your food against the rules in that restaurant. That's just not on.
So you don't want a rediscussion of the strategy?
Well, the strategy's there, it's in place. We're a long way, Raph, if I can put it to you this way, we're a long way from debating what the end point is. We need to get within range of that before we start having any sort of discussions about whether the strategy needs to change. Ultimately, let's get this stage 3 stay-at-home lockdown finished. Let's see community transmission at a much, much lower rate. Let's see case numbers at a much lower rate, and then we can make decisions about what the next period looks like. That's the only way. That's the only way to go.
They don't listen to Victoria any less in National Cabinet because of the problems that we've had?
I don't think so. I think you've got people working very hard in New South Wales at the moment, tracing all manner of people from one night at a pub. So I think there's an acute understanding across the board that this is something that moves very, very fast.
Premier's job started at in the past 20 years, 7.5% unemployment rate in Victoria. What extra help do you think the Commonwealth is going to need to provide to be sure, and I guess what can the state do to be sure that those Victorians on the belt here now aren't falling behind it?
Well, you've got some skills announcements that are a partnership between state and territory governments and the Commonwealth government, which I think have been made today. They've certainly been foreshadowed. Any additional money for TAFE and training is always welcome, and we'll put that to the best of uses, as we have these last six years, having rebuilt TAFE and having set it up to be a really strong provider of the skills that the economy needs today and that will certainly be needed in the years to come. In terms of that unemployment rate, that they're not numbers, they are families that are doing it very, very tough. Businesses that are equally doing it very tough. That's why there are a whole range of supports that we've put in place. We certainly can't rule out putting more support in place. We've got a budget later this year and that'll be exclusively focused on supporting families and creating jobs and the growth and activity that comes from the economy beginning to recover and make up the losses that we've had to endure because of this wicked enemy. That'll be there to fuel prosperity in the future. That's what our budget will be all about. I'm not here to speak for the Commonwealth Government or to make announcements on behalf of the Commonwealth Government, but I am, as I've said to you a number of times, I'm heartened by the fact that my conversations with the Prime Minister, numerous, my conversations with Treasurer Frydenberg as well, hardship is going to continue to drive their policy settings, and that means wherever that hardship presents, whether it be in a given postcode, a given industry, a business, a family, in any part of the country, then that support will be there to get people to the other side of this.
Premier, you put out a release on April 1 saying that you were going to put in an extra 4,000 ICU beds and worth $1.3 billion, but this is 1,000 ICU and critical care beds. So are we really behind target in terms of...
No, not at all, Alex. Not at all. There are orders that are fulfilled each week, each month. They were always orders that would take some time to fill. It's our hope that, of course, we don't need anywhere near that sort of capacity. That go back, April does seem a long time ago. That was always worst case scenario, and much of the modelling was predicated on not taking many of the decisions that National Cabinet has since taken, many of the decisions that we've taken just in the last week or so. We have adequate supplies. In fact, we have more than what is the projected need, but it's always good to have additional in reserve. And there are supply lines, and if I can take you back to that period, and indeed even more recent periods, where you literally had everybody in the world after the same product at the same time. So it was really important to secure, but not necessarily receive, a whole range of equipment. But it's there, sitting there if it's needed. The warehouse is full, and of course we'll have more and more of that deployed, depending on the number of patients that present.
So how many ICU beds are there? Because it says there's 1,000 ICU and critical care beds, so how many of those are ICU?
Look, I might ask the Minister to speak to the detail of that, but there are well more than is needed, and any suggestion to the contrary is simply wrong.
Okay. So we are seeing increasing hospitalisations in recent days, but our health system is well equipped to respond to the increasing demand. So all the work that we have done has been based on the epidemiology, on the modelling. We have currently 695 operational ICU beds, and we have the capacity to surge up and create more. If you look back at the announcement that we made earlier in the year, we were building new spaces. All of those projects are being delivered. There has not been any project that's run over budget, despite some media reports to the contrary, and those projects are still being delivered. So we were doing two things as part of the additional ICU capacity. One was creating new spaces, and those are the old Peter Mac project and other projects that I spoke about earlier. And then we have the capacity to convert acute beds and turn them into ICU beds, because essentially what makes that an ICU bed is the staff and the equipment that goes around that. So we can flex up and create additional surge capacity if that's needed, and we can do that by using existing acute beds, operating theatres, other critical care beds in our health system now. As I explained, we have lots of critical medical equipment sitting in our warehouse available to be deployed if we get to that point. So we have got lots of different stages in terms of the rollout of this. We hope that this capacity will never be needed. This is why we plan at the start of the year, worst case scenario planning based on the modelling that existed at that time. And since that time, we've had stage 3 restrictions now put in place that should stabilise the numbers. As the Chief Health Officer has explained, you know, we have expected about 2 weeks of big numbers. Today, of course, is a concerning number. It's a very concerning number, but if we all keep following the restrictions, we will see those numbers come down. We will not need to utilise all that additional capacity.
So what is the difference between a bed and a space? Because in your previous one you said 4,000 ICU beds, and now
Yes.
you're talking about 1,000 spaces for ICU
Yeah.
and critical care beds.
Yeah.
Do you actually
Yeah.
have any?
So unlike some countries in the world that can build a hospital in 10 days, you know, we follow OH&S rules, and we do these things in a considered way. So we did create some new infrastructure that is, you know, bringing forward the Casey Hospital site that also include additional ICU beds, bringing forward fast-tracking the Shepparton Hospital project, Goulburn Valley Health there, creating additional ICU capacity and emergency beds at Baxter House in Geelong, at Bendigo Hospital. So these are, some of these projects are actually new physical spaces that actually creates additional bed capacity in our overall health system. Don't forget we have 20,000 beds across our public and private system combined, lots of capacity in the system, but also the ability to convert existing capacity, existing beds, and turn them into an ICU bed. So if we were to do that, if we wanted to stand up that huge number of ICU beds tomorrow, effectively what that would mean is mothballing beds that would not then be able to be used for elective surgery. So we don't need to create that capacity right now. We have the ability to create more capacity, to surge up, to flex up if we need it, but we have 29 patients in ICU beds in Victoria at the present time. I don't want to see more patients. You know, it is on all of us to bring those numbers down, to stabilise those numbers, but we continue to do all the planning and all the work that's required. That's what that massive investment of $1.9 billion is delivering, essentially creating the ability of our health system to respond. But as the Premier has explained many, many times before, you know, if we let this just get out of control, we will have thousands and thousands of patients in our hospitals, and our health system will not be able to cope. And we've seen that play out in so many countries around the world. That's what we are trying to prevent happening here by asking the